Hi, my name is Jennifer Jones, and I'm going to give a presentation on congestive heart failure, also known as CHF. So heart failure is an epidemic with a majority of individuals affected over the age of 65. It is associated with high mortality rates and healthcare costs. It is estimated in the U.S. alone that 5.8 million people are diagnosed with or have been diagnosed with congestive heart failure, and over 23 million people have been diagnosed worldwide. Approximately 550,000 new cases are diagnosed in the United States each year. The mortality rates are high for congestive heart failure. Within 5 years, 50% of the people will pass away, and within 10 years, there's only a 10% survival rate. While most individuals affected by heart disease are not able to be cured necessarily, there are medications and lifestyle modifications that can ward off acute exacerbations of the disease. So now we can talk a little bit about the pathophysiology. Heart failure is a chronic disease. It is characterized by acute exacerbations. There are two types of heart failure. There's left-sided or right-sided. Right-sided is usually seen after somebody has been diagnosed with left-sided heart failure. Once their left side kind of deteriorates the function on the left side, the right side does become affected over time. The right side will become damaged. It causes congestion and edema. The blood and fluids in the body start backing up into other areas of the body, such as the lungs. Left-sided heart failure can be separated into two different categories. There's diastolic or systolic. In diastolic heart failure, the ventricles lose the ability to relax properly. When they're not able to relax properly, they're not able to fill properly, therefore they're not able to get the right amount of blood out to the body. In systolic, the ventricles lose the ability to contract properly. And again, if they cannot contract, they cannot get the right amount of blood out to the body through circulation. There are various causes of heart failure. Most of them include some damage to the heart at a previous time. There's coronary artery disease, which this can be genetic and hereditary. If you have a history of heart attack, myocarditis, faulty heart valves, hypertension, cardiomyopathy, congenital heart defects, arrhythmias can lead to heart damage over time. And then chronic disease such as diabetes, HIV, or thyroid disorders. Okay, so for the case study, we have Mr. H presents to the emergency room due to increasing shortness of breath and activity intolerance over the past couple weeks. He was taking out the trash earlier in the day and had a sudden onset of weakness and dizziness. He stated that he started sweating excessively and his heart was racing. He states that he becomes winded with normal activity and sometimes has to sit down to catch his breath. He also has noticed that his heart feels like it skips a beat on occasion and has noticed excessive swelling in his legs and feet. So the initial history and physical, he's a 72-year-old widowed retired male. He lives at home alone and admits to eating prepackaged meals since his wife's death 1 year ago. His past medical history is significant for hypertension and diabetes. And then his family history is significant for his father died of a heart attack at age 59. His mother is still alive, 95 years old. She lives in an assisted living facility. She suffers from deficits due to a stroke she had 5 years ago. So stage 1, we're going to do a patient assessment. Per the patient, they have gained approximately 10 pounds since their previous physical with their primary care provider 2 months ago. Their lungs are clear on auscultation with diminished breath sounds in the bases. They have +2 pitting edema in their lower extremities. Blood pressure is 144/86, heart rate 105, and O2 saturation is 96% on room air. BNP came back at 432 and A1C was 6.5. Liver and kidney functions were within normal limits. Potassium was decreased at 3.1. Sodium was normal at 138. Chest x-ray showed bilateral congestion in lung bases and enlarged cardiac silhouette. EKG was a sinus tachycardia, and an echocardiogram showed an ejection fraction of 35 to 40%. The initial physician orders are to admit to a telemetry unit and consult a cardiologist for a cardiac workup. Fluid restriction of 1,500 mLs a day, a low sodium cardiac diet, up with assist, 2 liters O2 for shortness of breath as needed, and continue home medications, but also add on to the orders potassium supplement, 40 MEQs POBID, We're going to add metoprolol 100 milligrams daily and furosemide or Lasix 20 milligrams IV twice a day. Nursing interventions at this stage. We want to educate the patient on the importance of calling for assistance prior to getting up. Patient would be considered a falls risk. They have had some weakness and dizziness. Also, since they're going to be on the Lasix, they are going to be going to the bathroom more. They're going to have a sense of urgency, so we want to make sure that they get help when they're getting up. We want to collect information regarding the patient lifestyle. Once we figure out the lifestyle that they've been leading, we can adjust and make modifications that's going to cater to the disease and ward off any exacerbations. You're going to educate the patient on the procedure in the morning and answer all questions within your scope of practice. There are some questions that are going to have to be left for the doctor, but you're going to do your best to answer whatever questions that you can at the time. And then instruct the patient on the importance of limiting fluid intake. This is a very important part with CHF patients, and it's one of the harder things to actually get them to comply with. Stage 1 questions. What factors put Mr. H at risk for developing heart failure? First of all, family history. His father died of a heart attack at age 59. There is a link between heart disease and family history. He also is both a diabetic and hypertension. Both of these chronic diseases put him at risk for heart failure. He also admits to eating prepackaged meals since his wife passed away. Prepackaged meals are known for being very high in sodium. And while sodium not necessarily is going to cause heart failure, it is going to aggravate the problem and bring on an acute exacerbation. What signs and symptoms does Mr. H have that indicate he may be suffering from heart failure? He has the increased shortness of breath, activity intolerance, he has weight gain over a short period of time, he has the lower extremity edema, and he has the elevated BNP. Stage 2. So in the middle of the night, patient rings his call bell about 2 o'clock in the morning and stating that he can't breathe. Nurse finds patient laying in bed, struggling to breathe. Patient is diaphoretic. His vitals are blood pressure is elevated 163/72. Heart rate is 135. O2 saturation is 87% on room air. Upon auscultation, nurse hears crackles in bilateral lungs. Pitting edema has increased to +3 in bilateral lower extremities. Patient has an empty water pitcher bedside, and PCT states that is his third pitcher of water since her shift started at 1900. She denies being told of any fluid restriction by the day shift PCT. So first, a physician orders typically administer 80 milligrams Lasix or furosemide IV stat. Going to do a repeat BNP and chest x-ray, and then continuous O2 via nasal cannula, 2 liters. Nursing interventions. Immediately you're going to want to sit the patient upright in bed and apply O2. This is going to help expand the lungs. This is going to allow them to breathe a little bit easier. You're going to want to call MD and report any change in the patient's status and receive the new orders. You're also, if with the new orders and if the patient condition does not seem to be improving or they seem to be declining, you're going to want to call a rapid response team to have them evaluate and decide whether or not the patient needs to be transferred to ICU. You're also going to want to, once you're done taking care of the patient, you're going to want to sit down with a PCT and explain the fluid restriction. Also, the rest of the staff members that you are working with, sometimes it's helpful to post a sign on the door to check with the RN prior to giving any fluids, because it's easy for other staff members, just if somebody's asking for water, to give it to them, and everybody needs to be aware that he is on a fluid restriction. Questions. Why does the patient need to be kept on a fluid restriction? Patients with heart failure have a difficult time of removing excess water and sodium from their body. This causes the fluid to back up into their lungs, which causes him to not be able to breathe and decreases his O2 saturation. So restricting fluids, keeps them from taking in too much that they can't get rid of. What is the purpose for sitting the patient upright in bed? Sitting the patient enables the lungs to expand, thereby aiding the patient and decreasing their shortness of breath. And what consideration should a nurse keep in mind when a patient is receiving furosemide? Furosemide is a potassium-wasting diuretic, and we know if there are any significant decrease or elevation in potassium, this can lead to cardiac arrhythmias. So we want to make sure that we replenish the potassium in their body. We want to make sure that there are serum electrolyte levels that are going to be checked daily. Also, the doctor already has a potassium supplement on board. Also, a patient is going to be at increased risk for falls because they are going to have an increased sense of urgency to use the restroom. For males, it's very helpful to have a urinal bedside as long as they're willing and able to use it. Bed alarms, any fall precautions should be kept intact just to ensure that the patient does not fall on their way to the restroom. Stage 3. So it's a couple days later, the patient had their stress test the next day that showed an ejection fraction of 40%, but no other abnormalities were noted. The cardiologist does not feel that a heart cath is necessary at this time. Patient is feeling much better and is able to ambulate around the nursing unit on room air without any shortness of breath. BNP is within normal limits at 78. Patient lungs are clear on auscultation, and edema in lower extremities has decreased to +1. Doctor plans to discharge patient home, and patient will continue to take the Lasix, metoprolol, and potassium supplements. Nursing interventions at this part, it's going to just be a lot of education. CHF patients, they need tons and tons of education. It is one of those diseases that you do get to see lots of non-compliance because they are on a sodium-restricted diet. They are on a fluid-restricted diet. These are the patients that they're repeat patients in the hospital. You see them a lot because they have a hard time complying. So you're going to want to educate the patient on their diet recommendations and fluid restrictions, go over healthy choices that they can make, something that they're going to be able to stick to. You want to educate the patient on signs and symptoms to look out for and when to see their primary care physician. Assess the patient knowledge regarding their condition and incorporate a plan of care with short-term and long-term goals that are reasonable for the patient to meet. And ensure the patient understands the importance of monitoring their daily weights. Questions. What resources are available to the patient in order to get a more well-rounded and healthy diet? Meals on Wheels is an excellent resource for the elderly in getting healthy meals delivered to their front door. Also, case managers should get involved. They can work with the patient and set them up with local resources. What diet modifications should be taken into consideration for patients receiving furosemide? Since Lasix is a potassium-wasting diuretic, increasing dietary potassium is always going to be beneficial to the patient. Potassium can be found in many foods such as bananas, sweet potatoes, acorn squash, wild-caught salmon, spinach, and dried apricots. And what signs or symptoms should prompt the patient to make an appointment with their primary physician? Any increase of weight, 5 pounds or more within a week, increasing shortness of breath or increasing activity intolerance, and a developing cough. And sometimes this cough is also they're going to develop a pink tinged sputum. Any of these would indicate that they should be seen by their primary care provider. So that is the end of my presentation. I hope you enjoyed it. Thank you very much.